Good morning. We're going to go ahead and get started. Am I loud enough? Good morning. There we go. We're going to go ahead and get started. I'm Michaela Green. I'm a physical therapist out of Austin. It's very nice to start our morning with y'all. You are in the session, It's Important to be Dense, Nutrition and Exercise to Improve Bone Density, and working with other endocrine issues. Going through bone disease is a common complication in adolescents and adults with CF. This session will explore the roles of the multidisciplinary team approach of diagnosis and treatment for those with CF related low bone mineral density. We will explore current methods of diagnosing and optimizing bone health from the perspective of an endocrinologist, a dietitian, and a physical therapist. We will review current exercise techniques, interventions, and considerations for individuals with CF-related low bone mineral density. Sorry, screenshotted all of my notes. So for our first speaker, I would like to introduce Dr. Haroon, Dr. Sarah Haroon. She's an assistant professor in the Department of Endocrinology and Mineral Metabolism at UT Southwestern Medical Center. Dr. Haroon earned her medical degree in Pakistan. She completed internal medicine residency training at William Beaumont Hospital in Royal Oak, Michigan, followed by advanced training through a fellowship program in endocrinology at the Medical College of Wisconsin in Milwaukee. Dr. Haroon joined UT Southwestern faculty in 2023. Dr. Haroon's clinical and research interests are bone disease and cystic fibrosis, menopause, and postmenopausal osteoporosis. Welcome, Dr. Haroon.
Thank you for the introduction. Okay, thanks. All right, guys. So I'm going to present cystic fibrosis bone disease. I have no disclosures. So in this presentation, I'll discuss the prevalence and pathophysiology of cystic fibrosis bone disease. I'll discuss screening for CFBD and highlight strategies for management of CFBD. So this is a figure from the 2023 CFF patient registry that shows the prevalence of osteopenia, osteoporosis, or fractures. And I'll refer to these terms later on in more detail in my presentation, but briefly, osteopenia refers to low bone density with T-scores between -1 and -2.5 on a DEXA scan, and osteoporosis refers to more severely low bone density with T-scores -2.5 or lower on a DEXA scan. So what this figure shows is that the percentage of people with cystic fibrosis who had either osteopenia, osteoporosis, or fractures was above 20% in individuals greater than age 30 and rose to 50% by age 60. This is so the consequences of impaired bone health of fractures, and it's very well known that fractures in CF are higher than the general population. This is a meta-analysis from 2010 that looked at a pool number of 1,055 people with CF aged 18.5 to 32 years and showed that the prevalence of vertebral fractures was 14% and the prevalence of non-vertebral fractures was nearly 20%. That's really high. We looked at contemporary data of females with CF aged 40 years and older from two centers, MGH and UT Southwestern, and we found that the prevalence of low bone density and fractures was still as high. So in our preliminary data of 76 females, 39% had osteopenia, 23% had osteoporosis, and 17% had had fractures at a mean age of 46.9 years. So there were a total of 17 fractures from our preliminary data, and the majority were rib fractures, 41% of all fractures, followed by wrist fractures that were 23% of all fractures. And this was followed by pelvis and humeral fractures at 12% each. But overall in CF, rib and vertebral fractures are the most common types of fractures. And fractures can have devastating sequelae in CF, such as pain and kyphosis, reduced lung function due to ineffective chest physiotherapy, decreased airway clearance, leading to increased pulmonary exacerbations. Multiple vertebral fractures can be a contraindication to lung transplant, and fractures can overall lead to decreased quality of life and loss of height, increased rates of depression. The figure on the right shows an X-ray of a patient with CF who had a sternal fracture, multiple vertebral fractures and kyphosis, and unfortunately had a fatal outcome. So, although we don't have data for this in CF, but in the general aging population, hip fractures increase with age, and they specifically have a high mortality, 21% at 1 year in the US, increased rate of nursing home admissions, and increased morbidity after surgery. So, we worry that as the CF population is aging, that hip fractures will become more common and affect quality of life and mortality. So, why are people with CF at a higher risk of fracture? One study conducted by Dr. Melissa Putman examined high-resolution peripheral quantitative CT, or HRPQ-CT, in people with CF aged 18 to 40 years compared with controls. HRPQ-CT is a scan that assesses bone at a very detailed level and is able to look at cortical bone and trabecular bone separately, similar to a bone biopsy. So cortical bone is a dense external layer of bone that's critical for load bearing, and trabecular bone also assists in load bearing. It's present in the epiphyses or the ends of long bones and also in flat bones. So what this study found was that people with CF had smaller bones and they had lower cortical volumetric BMD and lower trabecular volumetric BMD. And this technology also has a way of assessing how much force it takes to break bone. And it found that people with CF also had lower bone strength compared with controls. And this persisted even after adjusting for BMI and DEXA aerial BMD, telling us that skeletal abnormalities can exist in people with CF that are not detectable on a DEXA scan. And these findings were correlated with physical activity and percent predicted FEV1. The images on the slide show HRPQ CT scans of the tibia in a 23-year-old healthy volunteer and a 23-year-old woman with CF. So in the CF bone, you can see that the outer cortex is thinner, it has more porosity, and the trabecular mass overall is smaller than the healthy control. The individual trabeculae are thinner, they're fewer in number, and there are gaps or perforations in between. So before speaking further about CF bone disease, I'm going to talk about some normal processes in bone, and then we'll talk about how they are affected in CF. So bone modeling is a process that occurs in childhood and adolescence in which bones grow and change to attain adult shape and dimensions. And this is how peak bone mass is achieved in early adulthood. Bone remodeling is a process that occurs throughout life and consists of continuous osteoclast-mediated bone resorption and osteoblast-mediated bone formation. And in this way, old and damaged bone is continually replaced with new bone. So this figure depicts a general pattern of bone development and bone loss over a lifetime. During the first 20 years, bone starts to grow. Between the ages of 20 to 30, modeling takes place and peak bone mass is reached. And this is followed by the remodeling phase, which continues throughout a person's lifetime. The remodeling phase includes a plateau phase in which bone density is generally stable. After that, in women, a phase of rapid bone loss occurs in the menopausal transition, beginning in perimenopause. And after that rapid phase of bone loss, there's a more gradual state of bone loss that persists till the end of a woman's life. In men, there's no rapid phase of bone loss, but steady, gradual bone loss begins generally after the age of 50. So in the next few slides, we will show changes in bone and CF in the early and the plateau phases. So this is a study of 30 children and young adults with CF. And in this study, DEXA scans were done at baseline and at 1.5 years follow-up. The solid line curve shows lumbar spine BMD in healthy individuals, and the individual lines represent individual patients. And the connected lines represent the change in bone density over the 2 time points at baseline and 1.5 years. The solid line, fill dots are patients who were getting glucocorticoid therapy for most of the treatment duration, for most of the study duration. So what this study found was that at baseline, many children and young adults had low bone density to begin with, and over time, many of them actually had a decline in their bone density. And this is very significant because this is not a time period when children and adolescents are expected to lose bone, and instead they're accruing bone mass, their bone mass is increasing, but these people with CF actually had bone loss. And this is important because in the general population, lower peak bone mass is associated with an increased lifetime risk of fracture. So we worry that as the CF population is aging, they never had high peak bone mass to begin with, and they're going to lose bone mass with aging, with the menopausal transition in females, and they'll be at a higher lifetime risk of fracture. So now I'm going to move on to some studies assessing longitudinal changes in bone density. The first study by Tamer looked at 65 adolescents with CF and found that over 2 years, bone density at the lumbar spine and total body less head declined. And this was associated with a low baseline % predicted FEV1, female sex, and new onset CFRD. And this is again important because these are young children, and even though their bone density may be falling within the normal range for age and sex, again, bone density should not be declining, they should be gaining bone mass. Now, the next study by Jad is a much larger study. It's a very important study that tells us a lot about CFBD. It's about it included 500 adults with CF, and these are between 25 to 48 years of age. And it showed that progressively there was a decline in bone density at the femoral neck and lumbar spine. And this was associated with the presence of pancreatic insufficiency. So I'm going to pull up my previous slide just to demonstrate that the second study that I mentioned of adults between 25 to 48 years who had progressive bone density loss, so that's capturing the plateau phase in early adulthood when bone density is expected to be stable. So in summary, people with CF have a high prevalence of fractures. Peak bone mass may be low in CF, and longitudinal BMD loss occurs in the plateau phase in CF, a time when bone density is stable in healthy individuals. So there are many risk factors that contribute to poor bone health in CF, and these include chronic inflammation, CF-related diabetes, vitamin D deficiency, vitamin K deficiency, lung transplantation, malnutrition, CFTR dysfunction itself, malabsorption, hypogonadism such as testosterone deficiency or estrogen deficiency, reduced physical activity, which we'll talk about later, and glucocorticoids. So I mentioned in the last slide that CFTR dysfunction itself can be associated with low bone density. This is a study from neonatal bone section that showed that CFTR gene was actually expressed on osteoblasts. Those are the cells that make bone, on forming surfaces, and also in osteoclasts, which are the cells that break down bone, which are notable by their multinucleated appearance in the resorption pits. So even though we do not know what the function of CFTR is in bone, we do find that it is playing a role in bone disease in CF. So studies show that in CF there is an imbalance in bone remodeling that favors bone resorption or bone loss. So normal bone rank ligand binds to rank receptors on pre-osteoclasts that results in activation of these pre-osteoclasts into osteoclasts that go on to resorb bone. Activated T cells, such as in chronic inflammation, also increase rank ligand activity, which results in greater bone loss. Now, OPG is a molecule that's produced by osteoblasts and osteocytes that acts as a decoy receptor. It binds to rank ligand and prevents that interaction, which leads to osteoclast activation. So we can say that rank ligand is a bad actor and OPG is a good actor. And when we have a high rank ligand to OPG ratio, that results in net bone loss. So what happens in CF? So data from animal models and in vitro studies shows that with the delta F508 mutation, there is impaired osteoblast function and reduced OPG production, which will lead to increased rank ligand activity. And also in CF, as we all know, there's chronic inflammation, and that favors resorption through this pathway as well. So now that we've talked about the pathophysiology of CF bone disease, I'm going to talk about screening and management. So the gold standard for screening is a dual energy X-ray absorptiometry that measures bone mineral content and bone mineral density. In adults, we look at the femoral neck, total hip, lumbar spine, with or without the distal 1/3 radius. And in children and young adults, we look at the total body less head, lumbar spine, with or without the femur or the forearm. It's very reassuring for patients to hear that a DEXA scan gives very little radiation, even less than a chest X-ray, and it's a very straightforward test, probably takes less than 15 minutes. All right, so before I talk further about diagnosis and management, I'm going to talk about some key terms that we use. So T-score refers to BMD compared to a reference population of young adults, which is white females in their 20s to 30s. And we can think of it as what is desired. In older adults, we can diagnose osteoporosis with T-scores that are minus 2.5 or lower. And also in older adults, T-scores are very well correlated with fracture risk. Z-score refers to BMD compared to an age or age and gender matched population and reflect what is expected. A Z-score that's less than minus 2.0 in children and young adults is not equal to osteoporosis. We consider that to be low BMD for age. In this age group, Z-scores are not well correlated with fracture risk. And in children and young adults, we need to have a low BMD and the presence of a significant fracture or a vertebral compression fracture, irrespective of BMD, to diagnose osteoporosis. These are the screening guidelines from the CF Foundation that were published in 2005, and they're still valid today. So the CF Foundation recommends baseline screening for all patients after the age of 18, but starting earlier at 8 years if there is a specific risk factor, such as an ideal body weight less than 90%, FEV1 less than 50%, steroids greater than 5 milligrams per day for more than 90 days, delayed puberty, a history of fractures. So if any of these risk factors are present, bone density screening should begin earlier. So we would look then at the baseline T or Z score, and based on that, we would decide when the next bone density should be done. So if the T or Z score is minus 1.0 or greater, that is a normal bone density, and the next DEXA scan should be done in 5 years. If the T or Z score is between minus 1.0 and minus 2.0, that's not a low BMD per se, but it is an at-risk BMD, and so the next DEXA scan should be done in 2 to 4 years. If the T or Z scores are minus 2.0 or lower, then as I mentioned, that's low BMD for age, or if there is a history of a prior fracture, which indicates that bone quality is already poor, or if there's a significant BMD decline, and that's generally greater than 3% at the lumbar spine or greater than 5 to 6% in the proximal femur. So in those cases, the next DEXA scan should be done in 1 year. So how do we diagnose osteoporosis in people with CF? So we can divide that into two different populations. So in children and adolescents who have not reached peak bone density, generally less than 20 years of age, as well as premenopausal females and males less than 50 years of age, we consider osteoporosis when the Z-score is less than minus 2.0 and there is a significant fracture history. In pediatrics, a significant fracture history, according to the pediatric ISCD guidelines, is 1 fracture before the age of 10 or 3 long bone fractures before the age of 19. Or if there is a presence of a vertebral compression fracture, regardless of the BMD, that is also diagnostic of osteoporosis. And the other population is postmenopausal females and males that are greater than 50. And that's what I generally see. We diagnose osteoporosis when T-score is minus 2.5 or lower, or if there is a fragility fracture, which is diagnostic of osteoporosis, regardless of the T-score. All right, so now that we've talked about screening and diagnosis, I'm going to speak about how to manage CFBD. So prevention and treatment of CFBD is a multimodal approach. So initially, when I see patients, I want to make sure that we've ruled out some secondary conditions such as hypogonadism, celiac disease, which is highly prevalent in CF, and treat those other conditions. We want to make sure that we maintain an optimal BMI greater than 23 in men and greater than 22 in women. We want to make sure that vitamin D levels are normal, greater than 30 nanograms per ml. Patients should be taking vitamin K supplementation. We want to make sure that they're taking adequate calcium. And what's recommended for CF is a little higher than for the general population, 1,300 to 1,500 milligrams per day. Weight-bearing exercises are very important, and we also want to make sure that we minimize bone-toxic medications such as steroids. And other practices are important as well, of course, such as avoiding smoking, avoiding excess alcohol, avoiding excess caffeine, and maintaining good respiratory health, decreasing pulmonary exacerbations. So I'm going to speak briefly about exercise and mechanical stimulation. So bone has a way of sensing whether to increase bone formation. And in this diagram, the section of cortical bone is depicted. And I mentioned that cortical bone is this dense, thick external layer of bone that's critical for load bearing. And that is comprised of osteons. A single osteon is comprised of a central canal filled with nerves and blood vessels surrounded by concentric lamellae. And there's a type of bone cell that's housed in the mineralized lamellae called the osteocyte. And that's a really interesting and powerful cell. It has a chamber called the lacunae and canaliculi that can sense mechanical stimuli. And those can be different. So shear stress, hydrostatic pressure, mechanical tension, mechanical stress. So these are all sensed by the osteocytes, but not only the osteocytes, also osteoblasts, osteoclasts, and their progenitor cells also have a way of sensing mechanical stimulation. And what happens is that mechanoreceptors will sense loading and increase osteoblastic activity. What we see in the reverse is really much more dramatic. When unloading occurs, we see dramatic bone loss. So, for example, in post-stroke patients who are immobilized, or in astronauts who experience zero gravity, or patients who undergo bariatric surgery, really see that they have a remarkable amount of bone loss that's because of unloading. So how is this relevant to CF? So we know that people with CF may engage in low rates of exercise due to exercise intolerance, and there is at least one study showing a positive association between exercise capacity and BMD. Now, we don't have any prospective data for CF females, but in the general population for females going through the menopausal transition, it was found that increased leisure time physical activity, which was mostly walking, was associated with less BMD decline at the femoral neck. So I do counsel patients to do activities that they enjoy to avoid being sedentary, because even that will have a benefit in offsetting bone loss. All right, so now I'm going to talk about pharmacologic treatment. So who are the patients that we consider treatment in? So we'll consider treatment in those who have a Z-score that's less than -2.0, people who have had a fracture, which indicates that they have impaired bone health and they're at risk of having future fractures, patients who are having accelerated bone loss, those who have a history of prolonged oral glucocorticoid use, and those who are undergoing lung transplant, because fracture risk generally goes up after lung transplant because of bone toxic medications. Now, we do not have any CF-specific guidelines for menopausal women and older men, so we follow guidelines for the general population, which are to treat people with a T-score that is -2.5 or lower, or those who have an elevated FRAX risk, and that really refers to an online calculator, the FRAX calculator, where we can calculate for those patients who are osteopenic what their 10-year fracture risk is, and if it is above a certain threshold, we decide to treat them. Or if somebody already has had a fragility fracture, which gives them a clinical diagnosis of osteoporosis and means that they have a higher future risk of fracture. So in terms of treatment, really the randomized controlled data that we have for CF is limited to bisphosphonates, and we do have really good data for bisphosphonates in CF. So this is a randomized controlled trial of children and adults aged 5 to 30 years that looked at bone mineral apparent density of the spine. And in this trial, the bisphosphonate used was alendronate, and at 24 months, people with CF who received alendronate had a 17% increase in bone mineral apparent density compared to around 3% for placebo. This is a Cochrane systematic review of trials in adults who were on bisphosphonates compared with placebo. And this also showed that bone mineral density increased at the spine around 6%, with similar increases at the hip. So we all actually have a lot of options for osteoporosis, which is really fortunate. You may see that people with CF are now being treated with other agents apart from bisphosphonates. So I do want to go over them briefly. So we can divide pharmacotherapy into two categories: drugs that decrease bone loss or are anti-resorptive, and drugs that increase bone formation or that are anabolic. So drugs that decrease bone loss include bisphosphonates, and another agent is denosumab, which I'll talk about in the next slide. Raloxifene is a selective estrogen receptor modulator that also has a benefit in breast cancer risk reduction, and estrogen therapy, which can be used for menopausal females experiencing vasomotor symptoms, and that also offsets bone loss and decreases the risk of fractures. Now, medications that increase bone formation include teriparatide, which is a PTH analog, and abaloparatide, which is a PTH-related peptide analog. And these are daily pen injections, so not that easy to administer, but they do have very potent anti-fracture efficacy. And romosozumab is another anabolic agent that also decreases bone loss, and it's also very potent in decreasing the risk of fractures. So as I mentioned, bisphosphonates are anti-resorptives and they increase BMD in CF patients, but we do not have enough data for fracture risk reduction. And that may be because the numbers of patients in the trials were not enough and the follow-up duration was usually not longer than 2 years. And they do have some limitations, such as oral alendronate or risedronate can cause GERD, and GERD is a common symptom in CF. So in these situations, we can use IV bisphosphonates. And it's interesting that in CF, there have been case reports of IV bisphosphonates causing severe flu-like reactions that may be more severe and more frequent than in the general population, where they tend to be around 25% with the first infusion. So that's something to keep in mind. And another thing with the use of bisphosphonates is that when we're giving it to premenopausal females, we do worry about the impact on the fetal skeleton, because even though there has not been any negative consequence reported with the use of bisphosphonates, hypothetically, they can cross the placenta and enter the fetal skeleton. Denosumab is also an anti-resorptive. That's a monoclonal antibody against rank ligand, and I had shown the pathway for rank ligand, that it has a role in the increased bone loss associated with CFBD. So it may be a good option in CF. However, we don't have any randomized controlled trial data yet. There is an ongoing study. What's important to know about denosumab is that we can never just stop it. If we do, there can be rapid bone loss on cessation, so it needs to be transitioned to a bisphosphonate. And it's a very potent anti-resorptive agent. It will prevent calcium efflux from bone, so we want to make sure that patients are getting enough calcium and vitamin D while they're on this medication. Now, briefly, I'll speak about anabolic agents. I mentioned that they have high fracture reduction efficacy in the general population, so they're very promising for CF. But in terms of evidence, what we have is a case study of 4 patients who had a really robust improvement with teriparatide, and one case report of romosozumab that also showed a very robust gain in BMD. All right, so this is my last slide. So now that more and more patients are on CFTR modulators, we wonder what is the impact of these medications on bone. So this is a study, one retrospective study by Sermon Boitleus published in 2016, looked at 7 people with CF between 26 to 52 years, and they were treated with ivacaftor and followed for 1 to 3 years. And this retrospective study found that lumbar spine Z-score increased from -1.1 to -0.4, and that was statistically significant. But prospective data, as I'll show, have not demonstrated this bone density gain. So among prospective studies, a study by Dr. Putman published in 2020 looked at 26 patients with CF with the G551D mutation and compared them to 26 controls, and these included children and adults. They were treated with ivacaftor and followed for 2 years. And at the end of 2 years, there were no BMD changes on DEXA scan. However, with use of HRPQCT, there was a gain in cortical volume in CF patients treated with ivacaftor. Now, another prospective study by Gur looked at 9 CF patients compared to 9 controls, and these were young patients with an average of 18.6 years. And these were treated with ETI, and they had a DEXA scan done at 3 months after starting ETI, which is too short of a duration to assess change in bone. And this study did show that that bone density increased compared with the DEXA scan that was done 2 years earlier, but is most likely not attributable to ETI. Now, the PROMISE study is a prospective study that has ended, I believe, and we're waiting for the final results of that. But last year, they presented their preliminary findings, and they showed that among 65 adolescents and 79 adults with CF who were treated with ETI, followed for 2 years, there really was no significant change in BMD. It's possible that ETI mitigated that longitudinal BMD loss that may have occurred, but we'll wait for the final results of PROMISE before definitively stating that CFTR modulators do not have any impact on bone density. So I'm going to summarize my presentation here. So CFBD is associated with a high prevalence of fractures. People with CF may have low or normal peak bone mass, but they do undergo progressive BMD loss in early adulthood. With aging and improved survival, bone health of people with CF is likely to become a more important health issue. CFBD is multifactorial and primary prevention is key. It's very important to optimize pulmonary function and decrease exacerbations, encourage physical activity, optimize nutrition, ensure adequate calcium and vitamin D intake, and treat with appropriate pharmacotherapy those patients that are eligible. And lastly, the impact of ETI on bone health may not be as marked as its impact on PFTs and other outcomes. So thank you so much for listening.
All right, so I'm Allison Usher. I'm a physical therapist from Primary Children's in Salt Lake City. I'm going to present our next speaker. Sarah Hendricks is a certified advanced cystic fibrosis dietitian at the Medical University of South Carolina in Charleston. She's provided nutrition care for adult and pediatric patients in both inpatient and outpatient settings since 2014. Sarah participates in ongoing quality improvement and research in CF with publications in accredited medical journals and has presented at several national conferences. She serves as a dietitian mentor through the CFF and as a member of the MUSC CF Center Patient and Family Advisory Board. She was awarded Care Team Superstar by the South Carolina CFF in 2021 and CF Shining Star at the 2025 Nutrition and Social Work Consortium. Sarah has held numerous board positions for the South Carolina Academy of Nutrition and Dietetics, including president in 2020. Sarah graduated from the University of Arizona with her bachelor's in dietetics and completed her master's in nutrition and dietetic internship at the University of Georgia. She has been a dietitian since 2007, working as a critical care dietitian for the first part of her career. So if you can give her a round of applause.
Right. Good morning, everyone. I want to let you know my slides are available in the app. I will forewarn you that there's a lot more information in those slides because I uploaded them before I got feedback from Michaela and Allison about what would be good for PT discipline group to hear. I did give this talk a few years ago to the nutrition group, so it's completely changed since then, and I'm excited to share this new information with you, but you can follow along in the app if you would like. I have no relationships to disclose. So today we're going to go through nutrition status, body composition, protein intake, and how they affect bone health in our patients. Again, since this is a PT session, I'll talk about nutrition needs to support physical activity in our patients. We'll touch on CF-related diabetes, review the micronutrients that are important to bone health, and then wrap up with the dietary patterns that have the biggest impact. We know that low bone mineral density is associated with low body mass index in CF, and independent of BMI, it's also strongly correlated with low lean mass in our patients. And factors that can help with the maintenance of healthy weight and lean body mass are adequate calorie protein intake, appropriate pancreatic enzyme replacement therapy. And I think this part is important because as patients are feeling better on modulators, we're seeing a lot of self-adjusted doses and even patients who stop enzymes. And that can have a big impact on the nutrients that are important for bone health, on the absorption of those nutrients. And then we know physical activity is important for body composition. So adequate protein intake is important because it provides the essential amino acids that are needed for the synthesis of bone matrix proteins. So in particular, type 1 collagen, which makes up about 90% of the organic component of bone. Adequate protein also stimulates the production of anabolic hormones like insulin, like growth factor 1, which in turn promotes osteoblast activity and bone formation, and enhances intestinal calcium absorption. Also, adequate protein can indirectly influence bone health by increasing lean muscle mass, and this in turn enhances mechanical loading on bone, which stimulates bone formation. So we know that the majority of our patients have impaired protein digestion due to malabsorption. And this is addressed through pancreatic enzymes. However, again, if patients are self-adjusting their enzyme dose, their protein absorption may be up to half of what a person with a healthy functioning pancreas can absorb. And we know that low muscle mass is common in CF, and it's associated with low bone mineral density, declining pulmonary function, increased morbidity, and poor overall health outcomes. So this adequate protein intake helps to prevent the loss of lean muscle mass. And this is even when BMI is high or normal. And I think this is another important part to consider because we know that patients who are overweight or have obesity can still have low lean muscle mass, and we don't want to dismiss them as adequately nourished. When there's inadequate protein intake in the diet, this can affect bone health in a few ways. It can lead to decreased circulating IGF-1, which then diminishes osteoblast activity and decreases bone formation. Low protein intake can also lead to decreased intestinal calcium absorption, leading to low serum calcium levels. And this can have a rebound effect on the elevation of parathyroid hormone secretion. This promotes bone resorption in order to maintain calcium homeostasis. So calcium is released from the bone in order to maintain serum calcium levels. And then low protein intake also decreases the availability of those essential amino acids that are important for muscle protein synthesis. And we know that low muscle mass is strongly correlated with low bone density. So the recommended dietary allowances for protein are the minimum intended to prevent deficiency and maintain nitrogen balance in most of the general population. This is not necessarily optimal for patients who have increased physical activity or increased needs due to disease state like malabsorption and CF. So CF guidelines recommend protein intakes that are 1.5 to 2 times above the RDA. And although not specific to CF, a 2018 review by the International Osteoporosis Foundation concluded that dietary protein intakes above the RDA are beneficial in reducing bone loss and hip fracture. And this is provided that calcium is adequate in the diet. There is also some thought that high protein diets can be detrimental to bone health, and that's because they're associated with increased urinary calcium excretion. But this review also concluded that higher protein intake, whether from animal or vegetable source, do not appear to contribute to the development of osteoporosis or fracture risk. And in fact, insufficient protein intake is likely more detrimental than protein excess. So protein quality is defined by its essential amino acid density, its digestibility, and bioavailability. The digestible indispensable amino acid score, or DIAS, is the method used to evaluate the quality of protein in the diet. Animal-derived proteins are typically higher quality. They have higher DIAS values, more complete amino acid profiles, and higher leucine content. Leucine is one of the essential amino acids that is critical for muscle protein synthesis. So people following a vegan or vegetarian diet can meet their protein needs. It takes a little bit of strategic food combinations and selection of higher quality plant-based proteins. Most plant proteins are limited in one or more amino acids, and so combining different plant proteins like legumes with grains can make a complete amino acid protein. And then some of the higher quality plant proteins include soy products like tofu and soy milk, mycoprotein, which is derived from fermented fungus to imitate the taste and texture of meat, Andean grains like quinoa and amaranth, and then certain processing techniques like fermentation, germination, and enzymatic hydrolysis can enhance the digestibility and bioavailability of amino acids by decreasing those anti-nutritional factors like phytates in food that hold on to certain nutrients, and they modify protein structures too. So they can break down proteins into more peptide or amino acids that are easier to digest. So I wanted to just give you a reference for some common foods that are good sources of protein, and wanted to point out here that so meats, poultry, fish have about, let's see if we can show you here, have about 7 grams of protein per ounce. And a typical portion size, or at least the recommended portion size, is about 3 to 4 ounces of meat per meal. So translates to about 20 to 30 grams of protein per meal. And we can get protein from vegetables, soy, legumes, but it's not as dense in protein. So for example, tofu has about 3 grams of protein per ounce. And so again, we can meet protein needs with vegetables. It just takes a higher volume of these foods. And then dairy and dairy alternatives and some grains are other good sources of protein in the diet. And I thought it'd help to show just a practical example of how a child or adult could get their protein needs throughout the day. So ideally, we want to spread protein throughout the day and get it from different sources. So these foods provide not only protein, but a variety of those micronutrients that are important for bone health. And for a lot of our patients, meeting their calorie and protein needs can be a chore, especially for those with protein or fat malabsorption. And so supplements can be a way for them to help meet their needs. We know that oral nutrition supplements are associated with higher protein and overall nutrition intake and improve fat-soluble vitamin status. So we'll talk more about the fat-soluble vitamins later, but those are also important for bone health. And then a study showed that essential amino acid supplementation, especially mixtures that are rich in leucine, demonstrate highly anabolic effects in pediatric patients with CF. And this is regardless of their baseline nutrition status. And the patients who likely benefit the most from protein supplements would be those who are pancreatic insufficient, poor nutrition status, frequent exacerbations, or reduced muscle or bone mass. And there's a lot of options out there for protein supplements. Whey protein contains all of the essential amino acids. It's easily digested. It's ideal to promote muscle growth due to its leucine content. And then soy protein also contains all of the essential amino acids, so it's a good option for patients who are vegan or vegetarian. And then pea protein is highly digestible. It's also hypoallergenic, so maybe a good option for those with food allergies or sensitivities. And then we have concentrate versus isolate. And protein concentrate is probably a better option for our patients who are looking to gain weight. It's less processed, so it retains its original calories. And then isolate goes through a more extensive filtration process to remove the non-protein components. So it's higher in protein, but has minimal calories. It's usually more expensive and less palatable. And then I usually encourage patients to avoid extra additives and fillers, and try to limit the sugar alcohols that can lead to some GI distress. And it's also important to know that some patients can get these protein powders or other shakes through enzyme programs. Unfortunately, patients need commercial insurance to take advantage of it, but it's definitely worth talking with your dietitian about. And since I touched on protein supplements, I figured I'd say a word about creatine. This is something that's been coming up more in my clinics. I did not find any great evidence for creatine directly on bone health, but there is some new evidence supporting creatine supplementation for improving muscle strength in CF, which we know, patients with CF tend to have lower muscle mass, which is linked to lower bone mass. So this may indirectly benefit bone health. There was an older and small pilot study in pediatric patients with CF, and 12 weeks of creatine supplementation led to increased maximal isometric muscle strength and improved general well-being and with little side effects. And although we need more studies of creatine in CF, it can be thought of as a generally well-tolerated adjunct for muscle strength. And I'll say provided that renal function is normal in these patients. The dose shown to improve muscle mass in the general population is 3 to 5 grams a day of creatine monohydrate. And consistency is important for efficacy. The evidence-based studies are with daily supplementation. So, if I have patients just taking it after a workout, I encourage them to switch to daily supplementation. Okay, and since Jenny's going to go next and talk about exercise in bone health, I thought it was important to talk about some of the increased nutrition needs to support bone health. It's not uncommon for patients to come into clinic and lose weight and attribute that to increased physical activity through sports or exercise. And, we would never discourage exercise, but it's important they understand their needs are increased, not just for the physical activity, but for the disease state. And while some people on modulators may have lower energy needs, patients who are underweight still need to aim for higher caloric intake. Nutrition plans should be individualized, and then we want to encourage salt and fluid replacement that's lost through sweat. Bless you. So it's important for patients to have nutrients available during exercise to prevent further weight loss and to promote muscle mass accretion. So a carbohydrate-rich, moderate protein, low-fat, low-fiber meal within 1 to 4 hours of exercise can help to optimize fuel availability, maintain blood glucose, That low fat, low fiber helps to minimize GI distress. And like I said, prevents further weight loss and promotes muscle mass gains. So some examples might be a turkey sandwich with banana within 3 to 4 hours of exercise. And then generally, the closer you get to the exercise, you want a more digestible light snack and maybe even liquid within an hour before exercise. And then post-exercise nutrition is just as important, especially for patients looking to gain muscle mass. So optimal timing is within 30 to 60 minutes of exercise. This helps to promote recovery, supports muscle mass accretion, prevents further weight loss by replenishing glycogen stores, helps to repair muscle tissue, and restore hydration and electrolytes. And then continued intake of carbs and protein every 2 hours over the next 4 to 6 hours can further support that protein muscle synthesis. So ideally within that first 30 to 60 minutes of exercise, you want a high glycemic, easily digestible food. Chocolate milk is a common example. And then over the next hour or two, a high quality protein that's high in leucine to promote that muscle synthesis. All right, and so we're going to switch and talk a little bit about CF-related diabetes and bone health. It is linked with decreased bone mineral density and impaired bone accrual. And this pathophysiology is multifactorial. Insulin deficiency leads to decreased anabolic effects on bone. Patients with chronic elevated blood sugars have lower bone turnover markers. And we have longitudinal studies in children and adolescents with CF that show new onset CF-related diabetes is a negative predictor for bone mineral density. And we also know that impaired glucose tolerance and CFRD are associated with low bone mass accrual in youth. And this is after controlling for malnutrition, inflammation, and disease severity. So the recommended intervention for optimizing bone health in patients with CFRD is insulin therapy. So insulin helps to restore the anabolic effects on bone. It improves overall nutrition status and is associated with improved weight, protein anabolism, and lung function. So diet education, again, should be individualized. We want to optimize glycemic control and energy intake. And carb counting and insulin to carb ratio education can help to guide insulin therapy and maintain consistent glucose levels. All right, and we're going to get into some of the micronutrients for bone health. So calcium is the most abundant mineral in the body, with 98% stored in bone. And most of this is in the form of hydroxyapatite, which is an inorganic matrix of calcium and phosphate. And it gives hard tissues its rigidity, strength, and elasticity. It's vital for bone accretion during skeletal growth and maintenance of bone mass once growth is completed. And calcium intake should be screened annually. We do this as part of our nutrition assessment. And we want to note that the CF-specific vitamins do not contain calcium. And calcium deficiency can occur in CF due to vitamin D deficiency, which is common, and vitamin D helps to regulate calcium absorption. Reduce calcium intake, or really reduce milk intake. You know, we get a handful of people who are concerned that milk increases mucus production, and so they avoid it. There's no evidence for this, and so I really try to discourage that. Uncontrolled malabsorption can cause intestinal fat to bind free calcium and cause it to be lost through the stool. And just a side note, this is also the process that increases the risk for kidney stones in our patients. The calcium is lost through the stool, and we have higher oxalate stones. And then certain drug therapies like steroids can deplete calcium. So calcium guidelines for CF are in line with the general population. They range from 200 for newborns up to 1,500 milligrams. And so dietary interventions should aim to encourage increased calcium intakes. Most of the calcium in our diet comes from dairy and dairy alternatives. There is some interesting data on fermented dairy products and their benefit to decreasing bone loss or age-related bone loss. The thought there is that these beneficial probiotics and prebiotics modulate the gut microbiota. They alter intestinal permeability, increasing calcium absorption, decreasing pro-inflammatory cytokines, and decreasing bone resorption. And again, just another practical example of how we can get calcium in throughout the day. We really encourage, especially children, to get a good calcium source at each meal or snack. For kids who don't drink dairy milk, soy or pea protein milk is a good substitute. It has a similar nutrient profile to milk, to dairy milk. Rice and almond milk tend to be very low in protein and calories, so we try to avoid those as children are growing. And then this picture here is kefir, which is a fermented milk product made from beneficial yeast and bacteria. So it's got a lot of those beneficial probiotics and prebiotics. And if patients are not meeting their calcium needs with diet, a supplement should be encouraged. So there's two main forms, calcium carbonate and citrate. Carbonate is about 40% elemental calcium, so patients can usually get away with fewer pills to meet their needs, although this is best absorbed with food, whereas calcium citrate can be taken without food and may be better absorbed. Regardless of which form, absorption is best with doses of 500 milligrams or less, and so for a patient taking 1,000 milligrams of calcium, you want to divide that into 2 doses. So vitamin D's main role in bone health, sorry, getting dry, is to assist with intake of calcium, with the intestinal uptake of calcium. So in the absence of vitamin D, only about 10% of dietary calcium is absorbed versus 30 to 50% in a vitamin D replete state. Serum levels of vitamin D below 30 nanograms per milliliter can lead to parathyroid stimulation, which we saw promotes osteoclast activity and bone resorption. And it can also lead to decrease in intestinal calcium absorption. And vitamin D can be fairly common in CF for a number of reasons: fat malabsorption, reduced sun exposure, treatment with steroids, and then potentially poor adherence with vitamin D regimens. We do monitor vitamin D annually. It's ideally at the end of winter so that sunlight from the summer is not affecting the values too much. And the CF Foundation recommends we keep levels above 30 nanograms per milliliter. And we've got really great guidelines for vitamin D management in CF. This first reference here are those guidelines if you're interested in looking at those in more detail. It starts with routine dosing from 400 international units up to 2,000 international units, and then increasing up to 10,000 based on serum levels and adherence. Vitamin D3 is the preferred form over vitamin D2 because it has better efficacy for improving serum levels of vitamin D. We want to keep levels above 30, but not over 100 nanograms per milliliter to avoid toxicity. If a patient has persistent vitamin D deficiency despite confirmed adherence with their regimen, then it's recommended to refer to a specialist, such as an endocrinologist, to manage vitamin D deficiency. And then STOS therapy is a single high-dose oral administration of vitamin D3, usually 250 to 500,000 IUs. That's been shown to be safe and effective in CF and is becoming more common in clinics. So I'm showing this slide mostly to show that vitamin D is found naturally in very few foods. So it includes liver, fatty fish, eggs. Most of the vitamin D we get from diet comes from fortified foods like milk and ready-to-eat cereal. Most people will need a supplementation to meet their needs. And aside from supplements, most of the vitamin D that we get comes from sunlight. So there are a lot of factors that affect skin synthesis. So living, in the rainy Pacific Northwest is one of those factors. Sufficient vitamin D synthesis for adults requires 5 to 30 minutes between 10 a.m. and 4 p.m. at least twice a week to the face, arms, hands, and legs without sunscreen. The American Academy of Pediatrics recommends minimizing UV sun exposure for children, so supplements are recommended for pediatrics. Move on to vitamin K, and I'll give you just a brief background here because there are 3 isoforms. Vitamin K1 is synthesized in plants like green leafy vegetables, and it is the predominant form in our diet. Vitamin K2 is a bacterial byproduct found mostly in fermented foods and animals that graze on grass. And its 2 most common chemical variants are MK4 and MK7. And then vitamin K3 is a synthetic compound that's mostly found in supplements and animal feed. So vitamin K has several positive effects on bone. It helps to improve osteoblast function, regulates bone mineralization, prevents soft tissue calcification, and inhibits bone resorption. There is some new emerging and promising data on vitamin K2, especially when combined with vitamin D3. So vitamin K2 is involved in the carboxylation of osteocalcin, which is a protein that's needed for bone mineralization. And vitamin K2 may enhance the efficacy of calcium and vitamin D on bone health. Vitamin K is also commonly deficient in our patients for a few reasons. Fat malabsorption again, long-term antibiotic use, which kills that good gut bacteria that produce vitamin K, and then liver disease. And vitamin K is one of the least studied in terms of dosing and monitoring from all the fat-soluble vitamins, but the CF Foundation consensus guidelines recommend 0.3 to 0.5 milligrams daily for all ages. And our CF-specific vitamins do contain vitamin K. And we typically monitor vitamin K with annual labs. Serum vitamin K is not helpful. It just reflects recent intake and not stores. Ideally, we want to check PIVKA2. It's a sensitive indicator of early deficiency. However, it is a little more expensive and maybe not used quite as much. I think a lot of centers still tend to use prothrombin time. It's a later indicator and non-specific, but it is inexpensive and commonly used. Food sources of vitamin K are mostly, like I mentioned, those green leafy vegetables. Natto is a traditional Japanese food that's made from fermented soybeans, and it has one of the highest sources of vitamin K2. It is an acquired taste. I did try it after I put this presentation together, and it's... So phosphorus is a major component of hydroxyapatite in bones and teeth. And the majority of our body's phosphorus is stored in bone mineral. Deficiency is rare, and that's because it's so widespread in our food supply, both naturally and through additives. And excessive phosphorus intake is linked with adverse effects on bone. And this may be due to the decreased calcium ratio to phosphorus. And cola is kind of a unique one. It's linked to bone disease, likely because the phosphoric acid that it contains, which is readily and rapidly absorbed. And there is a thought that cola may displace milk in the diet, lowering that calcium to phosphorus ratio even more. So when phosphorus is deficient in the diet, there is decreased formation of hydroxyapatite crystals for normal bone mineralization. And this can lead to rickets in children and osteomalacia in adults. On the other hand, excess phosphorus stimulates that parathyroid hormone. It disrupts calcium and vitamin D homeostasis, leading to impaired bone mineralization. And this is exacerbated when calcium is low in the diet compared to phosphorus. So again, I've listed the recommended intakes. This is for the general population. We don't have anything specific to CF, but they range from 100 to 1250 milligrams, depending on age and gender. And so phosphates are found naturally in many foods. We get most of our phosphorus from dairy. The absorption rate for organic phosphates is about 40 to 60%. Inorganic phosphates are added to processed foods, and cola is the big one. And you can see their absorption rate is much higher at 80 to 100%. There are so many more nutrients that I did not get to cover today, just due to time restraints. But I think it's fascinating. So I've got all the references here if you want to look into any of these. And the takeaway is that these nutrients are found in a variety of foods. So we always get back to diet variety and whole foods. And one thing that's important to note, since we're talking about supplements, is that the FDA does not approve dietary supplements for safety before they go to market. This includes vitamin and minerals, protein powders, creatine supplements. So third-party testing is a good way to ensure that you're getting a good product. They ensure label is accurate, so it has the ingredients that it says it has, guarantees purity, and declares any undeclared ingredients. You can look for the certification seal on the bottle. Usually it's USP is a common one, or NACFC. If you don't see a seal, you can go to the manufacturer's website and look for third-party testing. When getting supplements from Amazon, you want to ensure that they're sold by the brand itself, by Amazon, or by an authorized reseller. So not just a third-party seller. There's a lot of those out there. But in the end, I know we discussed a lot of single nutrients. It really is so much more than single nutrients. So promoting a whole foods diet that is high in fruits and vegetables, dairy products, whole grains, poultry, fish, nuts, and legumes, and limiting processed foods, especially those that are high in organic phosphates, can have a huge impact on bone health for our patients. And I wanted to share some recipe templates with you that I created for my patients. They are available on the portal too at the end of my slides. But each of these recipes contains a lot of the foods that we talked about that have good sources of the nutrients that are important for bone health, and they're totally customizable. And with that, I'm going to pass it on to Jenny. Yes.
All right, so I'm going to introduce Jenny, our final speaker. Jenny Walzell is a physical therapist at Dell Children's Medical Center of Central Texas, their pediatric CF center. She earned her doctorate of physical therapy from Texas Women's University in Dallas, Texas. Jenny has presented and served as a roundtable facilitator, a speaker, and a moderator at the Northern American CF Conference. Jenny continues to be active and participates in CF Foundation committee teams and events to support the CF community. She's also currently the Pediatric Care Center's team captain for the Central Texas Great Strides. So let's welcome Jenny.
Thank you so much for that introduction. That was great. So yes, my name is Jennifer Walzell. I go by Jenny, and I am the pediatric physical therapist in Austin, Texas. I've been working in the CF population for the last 4 years. I did go to TW, but I actually got my bachelor's degree in exercise science from the University of Mississippi. So I've been in the exercise world for a long time. Today, I'm going to be presenting on exercise for bone health through the lifespan. I have no relationships to disclose. My objectives include describing the role of exercise in improving bone health, providing basic exercise prescription to promote bone health in the remodeling or the modeling phase of bone development, discussing exercise prescription to prevent bone loss in the remodeling phase, and to explain the precautions for exercise for those with osteoporosis. So first, why does exercise matter for bone health? In the general population, physical activity may reduce the risk of osteoporotic fractures by enhancing peak bone mass achieved during growth and development, slowing the rate of bone loss with aging, and reducing the risk of falls, and therefore risk of fracture due to falls, due to the benefits on muscle strength and balance that comes with regular physical activity. Physical activity is inversely associated with the risk of hip and spine fracture, so the more active you are, the less likely you are to have a fracture. Exercise training can increase, or at least slow the decrease, in spine and hip bone mineral density in adults, which I will speak on more later. Bone mass and muscle mass, or strength, are proportionally related. Under disuse conditions, muscle mass declines, followed by a loss in bone mass. And recovered muscle mass precedes recovered bone mass. So bone follows muscle. Therefore, in general, if you build muscle, you build bone, which is helpful when deciding on how to prescribe exercise. For CF-specific populations, we have the clinical care guidelines from the CF Foundation for Bone Health. These guidelines recommend improving nutrition status for low bone mineral density at all Z-scores. This includes optimizing vitamin D, calcium, and vitamin K, which Sarah just talked about in her presentation, but also increasing BMI to greater than 25% and encouraging outdoor weight-bearing exercise. So exercise can actually help with both of these 2 points, BMI and exercise. While exercise is typically thought of as a method for weight loss, it can actually lead to an increase in BMI through a gain in muscle. Bone mineral density decreases as weight decreases, with a 1 to 2% bone mineral density loss expected for every 10% of weight loss. Similarly, muscle mass also is expected to decrease with a total body weight decrease. This further puts stress on our CF population to maintain or gain weight as a means of maintaining bone density and muscle mass. Decreased physical activity is also one of the risk factors contributing to poor bone health. I am borrowing from Dr. Haroon, as she had this info on one of her slides listing the risk factors contributing to poor bone health. On this list, there are a few modifiable risk factors or risk factors that can be changed by a person's lifestyle, but physical activity is one of them. And if we can take away at least one item on this list, we should try. So in a study done on astronauts spending time in zero gravity, they found that over 6 months, these astronauts lost 10% of their bone mineral density. That would take roughly 10 years to do on Earth, and they lost it in only 6 months. I say that to say this: something is better than nothing. Today I'm going to talk about how to optimize bone health and the best exercises to do this, but at the end of the day, getting people moving at all is going to help their bones. So again, Dr. Haroon already shared this image, but I wanted to use it to explain the 3 parts to my presentation. Bone health changes across the lifespan. So first, we are going to talk about when bone density is being gained, which starts in childhood and continues into early adulthood. And this is called the modeling phase. Bone modeling occurs to accommodate the radial and longitudinal growth of bone during the growing years and to adapt the skeleton to mechanical strain. Therefore, exercise in adolescent years is important to gain the highest peak bone mass possible. Remodeling starts after peak bone mass is obtained and occurs to remove the micro-damaged and old bone, to adapt bone tissue to mechanical loading, and to maintain strength and integrity in the skeleton. The remodeling phase I will talk about in 2 parts, with the first being adults who are at risk for osteoporosis, and the second being those who already have osteoporosis. All right, so first up, the modeling phase. So my goal is not to go into detail on bone biomechanics, but it is important to have a basic understanding of how and why bone changes with exercise. Exercise leads to bone adaptation because of the cellular response to a mechanical load. Pictured are a few examples of loading, such as compression, tension, torsion, or a combination of any of these. You can think about the impact of landing from a jump as compression, the pull from two muscles in opposite directions during an isometric contraction as for tension, the twist of the arm of a baseball pitcher for torsion. The loading can come from ground reaction forces, again, think of landing from a jump, or it can come from muscle contraction, and you can think of the throwing example. Bone tissue gets deformed by this mechanical pressure, leading to a cascade of cellular responses, which leads to osteogenesis, or the formation of bone at the site of deformation. We also have this stress-strain curve, which demonstrates the mechanical properties of cortical bone. You can see here there's an elastic region in which if the bone is not put under enough stress or strain, it will return back to its original shape. Then you have this yield point B, which is where some permanent deformation of the bone sample occurred. So if there's enough force on the bone to reach this plastic region, you can have deformation that will lead to osteogenesis. What you want to avoid is the end of this graph, C, which is where the bone could not withstand any more force and fractured. A study by Deary et al. In 2012 did a population-based study on adolescents looking at habitual levels of physical activity on bone density. They used a Newtist accelerometer to measure the accelerations across several bands of gravitational force. The adolescents wore these bands for 7 days, and a number of impacts in the different bands of gravitational force were assessed. These related to normal walking, which was about 0.5 to 1.1. Brisk walking was 1.1 to 2.1. Jogging or running was 2.1 to 5.1, and jumping was greater than 5.1. These results found that the threshold for improving bone mineral density in adolescents is somewhere around 4.2 Gs of force. This would be accomplished by running greater than 10 kilometers per hour, or 6.2 miles per hour, or just under a 10-minute mile. I had to convert it. Jumping and then landing from a height of 38 centimeters or higher, which is about 15 inches. Again, to give more perspective, the average stair height is about 8 inches, and 3 soda cans stacked one on top of each other would be about 15 inches. For jumping, you can think volleyball, basketball, jump rope, high explosive jumps. Why this study is important is that it shows that all exercise is not created equal when it comes to building bone. While swimming is an excellent sport and has many benefits, it does not have the positive effect on bone accrual in adolescents that we would hope. So when it comes to prescribing exercise for children, you don't have to make it complicated. The recommendation for children is 60 minutes of active play per day. This can be structured or unstructured, but should include a variety of activities. To build bone density, they should be doing some high-impact activities like jumping, climbing trees, playing tug of war, playing on playground equipment, and running. As I stated earlier, muscle and bone are closely related, so most things that build muscle will generally build bone as well. For adolescents and preteens, the same 60 minutes per day is recommended. However, when prescribing exercise, adolescents have a greater skill set to participate in organized sports. Therefore, you can recommend organized sports such as basketball, volleyball, cheerleading, and track and field. These can be rec leagues or competitive sports. If the adolescent in question does not like organized sports and wants to do something more creative or freeform, you can consider rock climbing, both indoor and outdoor, martial arts, boxing, just running around their neighborhood or on the treadmill, or just use a jump rope in the yard. It really does not have to be complicated to be beneficial. For teenagers and young adults, the recommendation for exercise transitions more to that of adults, which means 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous intensity exercise. The teenage years is when I start to recommend weightlifting or structured exercise programs, although these could be started younger. Organized sports are still an option for this population, but many of them have either specialized in one sport by high school or will stop playing sports altogether by the time they enter early adulthood. Therefore, establishing sustainable exercise habits that are not related to school or sports programs in these years will be extremely beneficial as they transition into independent living. To build bone, we need resistance training and high-impact weight-bearing exercises. These include weightlifting, body weight resistance exercise such as push-ups, chin-ups, burpees, mountain climbers. I also really love high-intensity interval training for this population because you can combine resistance training and aerobics into one workout. It will also be able to be individualized and changed each time. As a small plug for myself, I'm in the middle of a research study where I'm providing standardized exercise education for teenagers in their CF clinic. And in that education, I provide them with a HIIT workout, which does exactly that. Some other options include, again, jump rope. You'll see, I really love the jump rope. I think I mentioned it like 6 times in this presentation. Plyometrics for those high gravity and high ground reaction forces, and of course, running, but not necessarily jogging. Exercise offers long-term benefits for bone health, such as shown in longitudinal and cross-section studies. A longitudinal study by Baxter, Jones et al. In 2008 showed that individuals who were active during childhood had an 8 to 10% greater hip bone mineral content in early adulthood than their peers who were not active. Another longitudinal study by Meyer et al. In 2013 had kids in 2 groups, one which engaged in school-based exercise intervention for 9 months and the other did not. These children engaged in school-based exercise interventions had a higher whole body, femoral neck, and total hip bone mineral content compared to their non-exercising counterparts. 3 years after they stopped the school-based exercise program, those in the exercise group sustained a 7 to 8% higher bone mineral content in the femoral neck and total hip. There was a cross-section study in 2014 by Warden et al. Investigating the long-term benefits of performing upper body exercise, specifically ball throwing. They took professional baseball players and looked at their throwing arm compared to their non-throwing arm as a control. And then they compared those to age-matched controls. The results suggested that half of the benefit of bone size and 1/3 of the benefit of bone strength was maintained throughout the life in a baseball player's throwing arm. Tivit et al. Conducted a cross-sectional cohort study investigating the long-term effects of soccer on bone mineral density, bone structure, and fracture risk in elite professional soccer players. They showed that exercise generated higher bone mineral densities, larger bones, and lower fracture risk in former athletes even 30 years after retiring from the sport. Increasing peak bone mass significantly reduces the risk of osteoporosis and fractures. Hernandez et al. In 2003 used a computer model to predict the relative influences of peak bone mineral density, menopause, and age-related bone loss, what those effects have on osteoporosis. And they estimated that a 10% increase in peak bone mineral density or peak bone mass would delay the onset of osteoporosis by 13 years, making peak bone mineral density the most important predictor of osteoporosis. That same 10% increase in peak bone mass can reduce fracture risk resulting from osteoporosis by up to 50% in postmenopausal women. Another study found a 6.4% decrease in bone mass in childhood has been associated with a 2-fold increase in fracture risk during adulthood. This evidence suggests that exercise interventions spanning childhood and adolescence are effective even after the activity has ceased. So here's one of my main points in this presentation. Exercise in childhood improves bone health in adulthood, even if the activity is not sustained over time. Again, something is better than nothing. So we return to this graph as we transition to the remodeling phase of the lifespan. In the remodeling phase, bone mineral density is gradually being lost, although there are several studies showing improved bone mineral density with exercise regimens. It is usually a 1 to 10% gain, which is not enough to reverse this curve. The truth is, all people will lose bone as they age, and the best we can do is to prevent further loss from inactivity. So in the remodeling phase, I broke this into 2 parts. First, we were going to go over the phase before osteoporosis, which I deemed the prevention and maintenance phase. And then later we were going to talk about osteoporosis. If we're going to talk about exercise prescription, we have to use the FIT model. If you had studied exercise prescription, you are already familiar with this model, but for those who need a refresher, I will quickly review the components. So frequency is how often the exercise is going to be performed. Intensity of the exercise is based on a principle of how intense an exercise must be to change the physiologic parameters to create an actual change in the body. For aerobic exercise, it is typically measured in a heart rate reserve or heart rate max. Heart rate reserve requires maximal exercise testing to calculate, and heart rate max can be estimated or tested through max testing. Intensity of resistance exercise is usually expressed as a percentage of the 1 repetition max, or the maximum weight person can lift one time. Again, this requires max testing. Time is how long the exercise is to be completed for, but volume is more often used for resistance exercise as it's expressed in reps and sets. And then finally, the type of exercise is just the mode of exercise that you're going to use. The American College of Sports Medicine recommends aerobic exercise 3 to 5 times per week at a moderate or very vigorous intensity for adults at risk for osteoporosis. Moderate intensity is defined as 40 to 60% of the heart rate reserve, and vigorous is greater than 60% of heart rate reserve. Since most of us do not perform maximal exercise testing necessarily in our patients with CF, I thought mentioning the talk test here would be appropriate. The talk test is an easy way for patients to determine their own exercise intensity based on how well they can talk during exercise. So if you can talk but not sing during an activity, you're usually at a moderate intensity. And then if you have to take a breath between every few words, then you're at a vigorous intensity. The time spent exercising can vary, but the recommendation is a total of 150 minutes per week of moderate or 75 minutes per week of high-intensity aerobic exercise. The type of exercise should be weight-bearing, and I listed several examples here. You'll notice they haven't changed much from the recommendations I gave for young adults. So the American College of Sports Medicine also has recommendations for resistance training for those who are at risk for osteoporosis. They recommend a frequency of 2 to 3 days per week of moderate to vigorous intensity resistance training. Again, since most of us don't do maximal exercise testing, I would like to use reps in reserve. So reps in reserve is where you use your own perceived level of fatigue to determine if you are at a moderate level intensity. So for example, if you're going to do push-ups, when you think, I could do 1 to 2 more push-ups with good form, but no more than that, then you're at a moderate intensity. If you do lighter weight, you generally need to do more reps, and for heavier weight, you can do less reps. You should also be including each major muscle group, which I listed here and provided some examples for each. Briefly, we have back, chest, arms, core, and legs. For back, there are bent over rows, lat pull downs, supermans, and back extensions. For chest, there's bench press, dumbbell flies, and push-ups. Arms, we have bicep curls, tricep extensions, tricep dips, chin-ups. For core, we have Russian twist, weighted sit-ups, leg lowers, and bird dogs. And for legs, we have squats, lunges, hamstring curls, bridges, and heel raises. Most of these can be done with or without weights. And of course, there's many more exercises for each group, but we just don't have all day. So here I provided a sample week for a resistance training program, and I've used this example in other presentations. It gives some options for body weight exercises and free weight examples. For resistance exercises, you do want to have a 2-day rest between muscle groups, which is why there are alternating days as well as rest days. The problem with giving examples like these is that it goes against the main principle of exercise prescription, which is that it should be individualized and tailored to the person performing it. This is one reason why research on exercise is so difficult, among many other reasons. But speaking of research, I wanted to take a minute to provide some of the research I found on exercise and bone density specific to those people with CF. However, whenever I started doing this research for this presentation, I found very few studies, and most, if not all, were correlational in nature, with no research on dose responses to resistance training and bone mineral density. So what I did find was a systematic review of the literature on physical activity and its correlates in people with cystic fibrosis from 2022. It revealed a positive correlation between physical activity and bone mineral density based on 4 studies which met the inclusion criteria. Rangolis et al. In 2003 did a correlation study to determine the relationship between exercise capacity, nutrition status, and dietary intake on bone mineral density in adults with CF. They found exercise capacity and BMI were significant predictors of bone density in CF, with higher exercise capacity and BMI being associated with a higher bone mineral density. Dodd et al. In 2008 then did a study where they looked at exercise capacity and bone mineral density and found that exercise capacity was an independent predictor of bone density in CF regardless of BMI. So there is little, if any, research done on resistance exercise interventions for bone density in the CF population. And a lot of these studies also looked at aerobic exercise capacity rather than strength or body composition. I personally believe this is due to the fact that before highly effective modulators, the lower life expectancy of people with CF limited the importance of bone density on health, and pulmonary function was the main focus of research. Because our CF population is now living longer, the need for exercise studies in this population continues to grow. So menopause in women causes a period of rapid bone loss due to changes in hormones. However, more gradual bone loss period follows this. Studies on postmenopausal women and exercise prove changes in bone density are minimal to negligible. However, please don't take that to mean that exercise doesn't matter. It still does. There is some, even if it is not statistically significant, improvement in bone mineral density with exercise even in postmenopausal women. Exercise also helps prevent loss of muscle with age, and therefore can improve overall health, as well as prevent falls, further reducing the risk for fracture in this population. So now we will transition to exercise recommendations during osteoporosis. So before getting into exercise prescription for people with osteoporosis, I wanted to inform you of the precautions for exercise. There are currently no contraindications for physical activity or exercise for those with osteoporosis. However, the precautions include avoiding trunk flexion exercises, as these increase the risk for spinal fracture. Trunk extension exercises and stabilization can still be performed. You want to avoid powerful twisting motions of the trunk. They should also avoid falls or high-risk activities which may result in a fall. Avoiding high-impact loading of the bone, as the bones are now more prone to fracture. If you remember my graph from earlier, the fracture or failure point will be more abrupt than previously. Similarly, avoiding vigorous weight-bearing exercises. You can still do vigorous intensity aerobic exercises, but just not in weight-bearing, so like in a pool or on a recumbent bike. So we are not going to suggest golf or tennis because of the powerful twisting motions. Probably not going to recommend skiing, especially with jumps, or basketball. We're not going to recommend equestrian riding or plyometrics, all of which are high impact or high fall risk. So what are we going to suggest? You'll notice this slide looks a lot like my previous slide. However, I removed the vigorous option for intensity and several of the options for the type of weight-bearing exercises. We still recommend a frequency of 3 to 5 days per week and 30 to 60 minutes of aerobic exercise, totaling around 150 minutes per week. The type of weight-bearing exercise will be walking, maybe jogging, climbing stairs, and other activities as tolerated. This doesn't mean they can't use a bike or swimming to get their aerobic exercise in, but as much as they can tolerate in gravity, they should. Again, any weight-bearing exercise will help slow the loss of muscle mass, and practicing balance in weight-bearing can help prevent falls and future fracture. For resistance exercise, the recommendations are also similar to adults who are at risk for osteoporosis. Recommendations for frequency and type of exercise has not changed. However, like aerobic exercise, I removed the option for vigorous intensity resistance training, as this is not recommended, although some people may be able to tolerate more intense exercise. I also crossed out a lot of the options for core, as they involve resisted trunk flexion, which can increase the risk for fracture. Bird dogs, supermans, planks, and other isometric or extension-based core exercises would still be appropriate. So if you didn't notice, the recommendations for intensity for both aerobic and resistance training intensities and those with osteoporosis still use variables which require maximal exercise testing. If you do not want to do a maximal exercise testing, or if you did want to do it, the American College of Sports Medicine recommends using a bike instead of a treadmill, and also considering that spinal deformities can compromise ventilatory capacity and may alter your results. While there is no established guidelines, maximal resistance testing may be contraindicated in those with osteoporosis. Personally, I would not recommend max testing in this population because common sense would say that maximally loading a muscle group with weight to failure would not end well if the bone is compromised. So before closing out on recommendations for exercise, I wanted to bring up a hot topic lately, which is the weighted vest. So there have been few studies on weighted vest, and most of them included exercise in addition to wearing the weighted vest, making it difficult to differentiate the benefits from exercise to those of the weight added from the vest. In theory, weighted vests add weight, and therefore they should increase the ground reaction force and stress on the bone. But they may not be the life-changing addition to exercise that some people hope it would be. A study by Keller et al. In 2022 studied weighted vests to prevent bone density loss in obese older adults during a weight loss program. The groups were divided into a weight loss group and a weight loss plus wearing the weighted vest group, where the weight of the vest was incrementally increased as the participants lost their body weight on a diet. Although there was no significant difference between groups, the group that wore the weighted vest for 10 hours a day had less hip and spine bone mineral density loss compared to the diet group alone, although both groups still did lose bone mineral density. Therefore, wearing a vest alone may help mitigate the loss of bone due to weight loss. The InVest study in 2025 was a continuation of that previous study and added a weight loss plus progressive resistance exercise group to determine if strength training had any impact on bone mineral density compared to the vest. This study found no significant difference between groups for bone mineral density or for weight loss. As expected with weight loss, there was also a significant loss in lean body mass or muscle mass. However, it was interesting that it was similar across all groups. So a weight loss of 10% should result in a 20% loss of lean muscle mass. But in this group, they only lost 8%. This maintenance of lean muscle mass despite weight loss could explain the similarity between bone mineral density between groups, given the relationship between muscle and bone. Although these studies do not show a significant improvement in bone mineral density, it does show that there's little risk to adding a weighted vest to a walking program. Therefore, if you have someone who wants to use a weighted vest, there's no reason to discourage them. So when it comes to prescribing exercise for your patients with cystic fibrosis, whether you're targeting bone health or something else, I want you to keep these things in mind. Exercise has such a negative bias for most people, but it can be fun. Make sure you're considering what the individual person would enjoy doing and make them a part of the process. Getting buy-in is so important to compliance to the exercise prescription you're making. Also, form matters. I say this because it's often overlooked. If an individual is not doing the exercise correctly, then it likely isn't doing them any good and may set them up for injury. When in doubt, consult a professional, whether that's the PT in your clinic or if you have to refer them out to a local trainer at a gym. Exercise only works if you do the work, and there is no replacement for the benefits you get from exercise. If exercise was a pill, everybody would take it, as the benefits are far-reaching. You will have to consider the cost-benefit analysis for some patients. For example, a patient with arthritis should not be doing high-impact or high-intensity exercises regardless of their bone health. Those individuals would be at a higher fracture risk later due to their inability to load their joints. However, the damage to their existing joint health now would not be worth the trade-off later. For our CF population specifically, consider their lung function and adjust the intensity accordingly. You must also consider the psychosocial aspects of exercise, including an individual's access to a gym or the financial cost of equipment or a gym membership. For this, I would reference your social worker, but there's also usually grants available for equipment. And remember, something is better than nothing. So while you may feel like walking isn't doing enough for your patients, it is doing a lot more than them just sitting on the couch. All right, questions. I think it's open for questions for everybody, right? Okay.
You have some questions already in that.
If you want to sit, yeah. All right, so we're going to do a panel with all of your questions. So we're here in the app. The first question, do you think the CFF DEXA guidelines are comprehensive enough to catch early bone disease? Are there clinical characteristics that we should be mindful of when we're advocating and educating for our patients to get a DEXA? I'm going to give that one right to Dr. Haroon.
Yeah, that is a very good question. I think that they are comprehensive because they do take in mind the specific risk factors. And if you can look them up, the first author is Aris in 2005. And so if there's low body weight, low FEV1, history of steroid use, delayed puberty. So with specific risk factors, bone density screening can start as early as 8 years. And also, if someone has had a fracture, and we are advocating for a rib fracture to be considered a fragility fracture in CF. So if someone has already had a fracture, then even if their bone density is normal, I would be more vigilant about bone density screening. So they should get an annual DEXA. So I think the guidelines do offer guidance beyond what is recommended for healthy pediatric individuals. And then your question about certain clinical characteristics.
Yes. The question was, are there clinical characteristics that we should be mindful of when we're advocating and educating for our patients to get a DEXA?
Yes, yes. So definitely, so low body weight, low FEV1, a history of delayed puberty, prolonged steroid use. So again, those are all the risk factors that are, a part of the guidelines. The DEXA is a really good screening tool to pick up low bone density, but it's true that in CF, fractures can occur when bone density is normal. So there's definitely limitation. However, other modalities such as the HRPQCD is a research tool. It's very expensive. We do not use it clinically. So hopefully things will change in the future, but we have to work with the tools that we have now.
Do you have a question?
Yes. I'm a dietitian at Cook Children's in Fort Worth, and sadly we don't have a PT at our clinic, so we kind of have to approach physical activity in the multidisciplinary setting, and a lot of times it does fall to me. And I'm struggling with a lot of my preteen patients. They're very much interested in video games and like the iPad and TV, and it's the parents buy in when I recommend increased physical activity, but it's really hard to get the kids interested. So if you guys had any, creative solutions with that population, because I think preteens, like, they're just learning how to kind of manage themselves, like, outside of their parents' help, and we can't force them to do anything. So yeah.
I'm sure there's a lot of people in this room that would have thoughts on that too, but I try to coach them through it. I try to bring up different options, like whether it's school-based or if it's a rec league, or if they could just go, somewhere after school that's not going to put them in front of a screen, that kind of thing. But yeah, just trying to find something that interests them and that they will stick with. Yeah.
I can also answer when they become adults and they still want to be on screens and play video games, making it interactive and having a buddy. So if the parent is engaged, asking them to do walks together or find exercises that they like to do together. I had one patient that was like, I love to play DDR with my mom. So they played DDR together, and it was weight bearing, and it was fun, and it was still exercise. There's a lot of technology out there that makes it exercise a reward. And so there are some free things out there that can make it fun and interactive.
I ended up paying a personal trainer to come to our house. And my son doesn't do things for this man. And so, it's expensive, but it's been absolutely worth it. Strength and all of those things. Like, he's not an exercise kid. So those kinds of incentives. I also started paying my kids at one point. Now my daughter does it on her own. She loves doing it, but my son really responded to it. Sometimes you can get physical therapy covered by insurance, and they work with a trainer, especially the younger population, and they make it fun. This is a recording.
Oh, great. Thank you so much for that insight. That is so helpful to hear, and I think hopefully sparks some interest and imagination for other providers. This is a recorded session too, so thank you so much for sharing that. If we just want to make sure that all of those amazing comments and feedback get to the mics for future ones. Thank you so much. Oh no, you're wonderful. Thank you. We'll take your question next.
Mary Rossi, diabetes and obesity medicine at Tulane in New Orleans. And she's said she's had a personal trainer for her kids with CF, just for people listening to it recorded. Comment to add on to that, and then a question. I actually have some of my moms turn off the Wi-Fi, and their parents have to buy, or the kids have to buy time, equal time exercise, buys, whatever. And I tell them ignore the AAP guidelines. And if their kid wants to exercise or be active, I call it activity. I take out the word exercise because it has negative connotations to them. Active time. If their kid wants to be active for 5 hours, I don't care if they're on the internet for 5 hours, as long as their parents are okay with what they're on the internet. So I call it buying the time. That actually works fairly well sometimes in some of my patients. I find that the internet is pretty motivating. The then question kind of from the weight loss perspective, and now with the modulators, and knowing that we are seeing loss of lean mass, including bone density, now with our patients on weight loss medications. And I've started actually getting pre-DEXAs in all of my patients. So I do pediatrics before they're on any highly effective weight loss medications, because I'm really concerned about these, particularly my girls, before I put them on when they're in their bone building years. And now I'm concerned because I'm probably going to end up having some CF patients who are now going to end up on some of these medications. And just kind of getting some perspective on that. How should we be looking at these patients as we're putting even more high risk group on there? Should we be screening them? How often do you think? I know that there's no guidelines on this, but like, how often do you think we should be screening these patients as we're putting them on GLP-1s and such? Because I really, really worry about these girls in particular, but also my guys.
I'll just start with that. And I know this is not accessible to everybody, but we recently got a body composition scale and are specifically with those patients that we're sending over to the weight management center. We're getting baseline body composition.
I do have, I don't know how I talked the hospital into buying me one since I can't bill for it, but I do have one. And I actually threaten them that if they lose too much lean mass, I will take them off of their weight loss medication. And so that also sometimes gets me exercise too.
Yep. Yeah.
Do you have any?
Yeah. I think for me and my patients, we also have an in-body machine that we use. And then we talk about skeletal muscle mass versus fat mass loss. And so all of those females that, because they've heard their whole life, eat, you need to eat more calories, you need to eat more calories. And now we're in a season where like, well, let's readjust that. And there's a lot of body image issues currently, and that's being researched as well. And so being sensitive about that topic, as you talk about activity, and bone health has actually been huge and instrumental, and say, if you build the muscle, you build the bone. So it's not about weight loss, weight gain. If you're doing the activity that you enjoy and you're building that skeletal muscle mass with those numbers, because then you can see on the in-body, a lot of the patients like that input to know, okay, I might have gained weight, but it was skeletal muscle mass, or I might have lost weight and I didn't lose the muscle mass. So I'm doing the right thing. And so I work with our dietitian to really have those conversations that are sensitive, but also help them for their future. Yeah.
So like the DEXA screening, we don't have, cohesive evidence showing that the GLP-1s cause bone density loss, but anyone with a large amount of rapid weight loss would be at risk of having bone loss too. But they are, for the general population, there's no difference in terms of DEXA screening. But that's a really good point, and I think that's something that we're doing. Research is being done for non-CF patients on GLPs to understand, what their risk of having bone loss is. Right now, we don't really have evidence showing that there is. I would just say, focusing on building the skeletal muscle mass, and I would not. Because of the lack of evidence, would not go for pharmacotherapy. So therefore, I don't think we need to really get a bone density. If they started out with normal bone density, I wouldn't really worry about getting another bone density in just 1 year, but I would just focus on healthy habits and building skeletal muscle mass. I hope that helps.
Hi, great presentation. My name is Asta. I'm the physical therapist with the Adult CF Clinic at Columbia. Question and also like a discussion for PTs. I know with imaging, we have the bone density test and as well as the body composition. But as PTs, is there any screening tools that you use? We've recently started seeing more and more adult diagnosis, CF, so late diagnosis, and it's even though the guideline is getting a bone mineral density if they're osteoporosis every 2 years. We have on the lung transplant team, especially the advanced late diagnosis CF, we've started doing frailty testing, which is helpful for that. But I'm curious to know with the PTs on the panel or otherwise, if there's any other screening that you do for our patients, especially on the adult side for bone mineral density.
Yeah, I can take that question as the adult PT. I have done grip strength testing. There is some research out there that correlates decreased grip strength with decreased bone mineral density, but not specific for individuals with CF. We also have done like the squat test to fatigue, just so they have a baseline and to see where they go from there. I have used some balance assessments for some of the older patients that we have that are concerned, especially if they've had a lot of vestibular issues and they're tripping and falling more frequently. Yeah.
Thank you. Anyone else?
Yeah, anybody else in the room? Because I'm not the expert.
I work at a pediatric center, but our endocrinologist talked a lot about lateral spine films as a way to look at vertebral height and screening if you're not going to get a DEXA doing that on the in-between years. I don't know if you have any thoughts about that, but it's something that we've looked at because people are getting chest x-rays. It's one more image that you can get to kind of monitor that.
I think it's a great idea, especially because the incidence of vertebral fractures is so high in CF. I think it's a wonderful idea.
Hi, everyone. Thank you for your talks. My name is Taylor Lewis. I work at Precision Performance Institute. I'm a strength coach and exercise physiologist. And there's a big debate on both sides about exercise programming when we talk about bone health. Yes, we want cardiorespiratory health. We want to improve that. But how do we mitigate that with injuries and stuff like that? So I do think we need to start talking more about actual specific programming, because the American College of Sports Medicine is great on giving us general things, but everything's very specific towards the individuals. So do you guys have tips on programming when you're trying to improve higher intensity interval training? Knowing ground reaction forces, depending on landing and depending on exercise, can elevate, 8-10 times body weights and forces. Are you 1 time a week, twice a week? Or on top of that, do you have strength standards that you look at before you integrate like jump roping and stuff like that?
Go ahead.
Oh yeah. I was gonna say we'll do hand grip strength testing as well. And with kids coming to clinic quarterly, like really focus on meeting kids where they are, what they're willing to do. So I will give them a recommendation, like I would love for you to try and do this twice a week, but even and plan a check-in, whether it's 2 weeks or a month out, and just see how things are going. We used to be able to provide virtual therapy sessions, and we're able to kind of have, kind of not the most wonderful, some feedback visually. But I feel like I normally will try to encourage twice a week, and really just focus on 1 to 2 exercises in each muscle group, back, core, legs. And I feel like just from a sustainability standpoint, start there and then really build. I feel like that's been the best buy-in. I'm not sure about Jenny and about Michaela, but I feel like by the time I see a lot of kids on our clinic visits, sometimes too, that information overload is hit. So I think it's just meeting kids where they are and really just providing that education. This is so important for your bone health now, and moving into being at the adult center, because we don't have an adult PT at the University of Utah. So really kind of trying to do that preemptive, preventive education.
Similarly, I think that a little bit with PT in clinic, we are at a disadvantage because they're not there, like they're there for so many other things. And we are just like, we're throwing one more thing at them, and to give them, you know, like you need to be doing, like you need to change everything in your exercise program. Like we're going to do this, this and this. It's not their priority. They got a lot going on. They got a lot of meds they're taking, a lot of things that they're concerned about. So yes, getting like 1 to 2 things in, or even if I could just convince them that it matters first, that'd be great. And then whether they act on it or not is kind of up to them.
Yeah.
Have you used strength standards of any way to see if they're ready for plyometric based, you know, jumping or anything, whether it's a squat, whether it's, you know, be able to do something before you start to have them jump or move in positions that could cause more stress to bone?
In my clinic, my kids are doing I have a handful that are like at a pretty good risk for developing bone issues right now. But in general, they're all really still safe to exercise. So I don't know if y'all have come across that more.
Yeah. So for me, I had similar questions, like how much do we need to do? What is the dosage? What are we looking at? How often can we make a change? And so I have a very small study right now with 12 patients, and I did an 8-week strength training program. Did I follow up with them? But no, but like we went over all the form of the exercise program, and then looking at resistance in the gym versus there's a at-home program and an in the gym program. And so not to plug, but case study tomorrow talking about one patient that I have that did perform the 8-week strength training program. And she was able to go from osteoporosis to osteopenia in 2 years, and then now is in the normal category. So not saying that what I've created, I enjoy strength training and that's my cup of tea for exercise. And so knowing what knowledge I've learned for myself, and then applying it to the patients. But yeah, there's just more research that needs to be done. Yeah.
Thank you, guys.
Ooh, we've got 3 minutes. All great questions. Matt, you okay?
Sorry.
Yeah.
I was just saying hi to Taylor. So thank you all for speaking. This was a fantastic session. I want to put a little plug in for Dr. Haroon. It was on one of her slides, the CFF guidelines for the pediatric population from 8 to 17. Our clinic did a QI project that I was a part of in screening all those children within that age. Extremely long story short, about 50% of them came back as having low bone density, the ones that fit that criteria. So we did get a lot. I know you asked about sensitivity. So are we missing some? I don't know if we're missing ones from that criteria, but I was pretty shocked that 50% of them did test positive for low bone density. So I think that's a really good start for the kids who fit in those criteria. It was kind of a lot in math and stuff with the glucocorticoids and adding those things up. But on EMRs, that stuff was real easy. I didn't really have to see the kids. I just sat at the computer and went through with, calculating ages and things like that. So it's a really good, I think it was a good start. And then there was one more question on here that we didn't get to that I want to pull up to the top regarding the difference between osteoporosis and osteopenia. I think this is more towards Jenny. As far as you mentioned osteoporosis in the exercise guidelines, can we be a little bit more aggressive with those who have osteopenia? Or don't we know?
Yes, I think you can be. Again, the osteoporosis definition is based on the Z-score on their DEXA scan. So it's like if they've hit that, then that's now they have osteoporosis. Okay, so correct me if I'm wrong. So the ones at risk for osteoporosis or in the osteopenia, those other exercise recommendations that I gave, where the intensities are actually a little bit lower than for just general adults. If you didn't notice, vigorous was greater than 60%, which, and the general population, we would say it's more like 80% would be vigorous. So, but yes, you can. And again, there's nothing that says that they can't do it. And for some individuals, vigorous is still okay. It's more so, I think everybody's hesitant because they don't want to say, yes, it's fine, and then have somebody get hurt. But that's again where it goes back to being individualized. So if you have somebody, like I gave all those examples, those like silly examples of like somebody like jumping on skis, but if they've been a downhill skier their whole life and they're really stable and that's something they love to do, and it does like, it has bone density benefits to it, who's to say that they can't keep going, you know?
Yeah.
Thank you.
For me, I also consider the age with the category. If they are a little bit older and they are in that menopausal, or premenopausal age, I adapt it just a little bit. Yeah. We'll take the one more question because we are at time, and then our speakers will be available post if you have more hot topic questions.
Thank you for taking my question. I'm Candace. I'm a pediatric endocrinologist, and my question had to do with the screening of 8-year-olds, particularly those with delayed puberty in the CF population that tend to be smaller in size and stature already. And so by using Z-scores, we're comparing them to age and gender matched norms that are of average size. And so I just wondered about, are we overcalling bone mineral density issues, or are they just at risk where it's worth screening, or do we need to correct for smaller stature? Thanks.
Thank you for bringing that up. And someone asked online as well. So I'm not a pediatric endocrinologist, but I do know about the CHOP Z score that someone mentioned as well. That's something that adjusts for height. And I believe that it's only available for Hologic. And it is available online. I don't remember the website off the top of my head, but that is one way to correct for short stature, because with smaller bones, areal bone density is going to be lower and it'll be falsely low. So definitely bone mineral apparent density and height corrected Z-scores are, two ways that we can adjust for smaller height, with the height corrected Z-score being superior. So that's a great point. Thanks for bringing that up.
All right. Thanks, y'all. Thank you for, yeah.